This study really got my attention and it asked a really important question. What if during cranial cruciate ligament surgery, we may be treating some meniscal tears that never needed treatment in the first place? So a new 2026 study followed more than 200 canine knees where surgeons did something really unusual. They didn't even look at the meniscus. Here's the controversy. When a dog tears its cranial cruciate ligament, meniscal injury is extremely common. It's been reported 33 to 83% of cases. So during a TPLO, we traditionally explore the joint either with an arthrotomy or arthroscopy. And if the medial meniscus is torn, the damaged portion is typically removed. Seems logical. But there's a problem. Meniscectomy isn't biologically free. The meniscus isn't just a useless piece of cartilage. It helps distribute load across the knee and affects contact mechanics. Experimental studies have shown that both meniscectomy and meniscal release alter the biomechanics of the canine stifle. So these researchers asked a provocative question. What happens if we stabilize the knee but leave the meniscus alone? This was a retrospective study of 191 dogs and 236 stifles undergoing high tibial osteotomy, either TPLO or CCWO. The surgeons intentionally used a meniscal sparing approach. No routine arthrotomy, no routine meniscal evaluation, and therefore no routine meniscectomy. After surgery, 37 of the 236 knees, about 15.5%, developed a latent lameness at a median of about 141 days. Here's the fascinating part. They didn't immediately take those dogs back to surgery. They first ruled out major complications and treated suspected meniscal injury non-surgically. Now, 24 of those 37 knees improved without meniscal surgery. That's just 5.5%. And this wasn't simply ignoring dogs that needed surgery. All 13 dogs that failed conservative management had underwent arthrotomy actually had meniscal tears. 10 were bucket handle tears and 3 were complex tears. There were 0 negative arthrotomies. Long-term follow-up was obtained at around 3 years, and when researchers compared validated load and canine orthopedic index scores, there was no significant difference between the dogs that eventually needed meniscectomy and the dogs whose joints were never explored. This raises a much bigger question. Does finding a meniscal tear automatically mean that that tear is clinically important? The authors suggest that some meniscal lesions may simply not require surgical treatment, and stabilizing the knee with an osteotomy may limit their clinical impact. So maybe the goal shouldn't always be find the tear and remove it. Maybe it should be identify the tears that actually need treatment. This study did not prove that we should stop evaluating meniscus during TPLO. It was retrospective. There was no randomized control group. And because the surgeons intentionally didn't explore the joints, we don't actually know which dogs had meniscal tears at the time of their original surgery. The authors specifically say that a prospective randomized study is needed here. But in 236 knees where the meniscus was initially left alone, only 5.5% ultimately required meniscal surgery. And some dogs that developed late lameness improved without meniscectomy at all. So this paper asks a question that could challenge a pretty entrenched surgical practice. During a TPLO, do we need to treat every meniscal lesion that we can find, or only the ones that actually are causing a clinical problem? Follow me for more evidence-based veterinary medicine.